Hello, good morning. Thank you for joining. Give us just a couple of more minutes. We're going to give others a little bit more time to join. Thank you. Hi, good morning. Thank you for joining us for the Take 5, How eCQMs Improve Patient Care and Outcomes webinar. My name is Christy Washington, and I'm the Pop Health Analyst for Health Information Technology here at DCH. I will be your moderator for this webinar. This is part 2 of a 5-part series where we take a closer look at 2 eCQMs to provide the benefits of entering your clinical quality measures and how it will aid in providing quality health care to Georgia's Medicaid population. Jeff Jacobs with DXC Technology will present an overview of the project, followed by a system presentation by Teresa Harris, also from DXC. Chris Huckabee with Health Tech Solutions will present 2 eCQMs for women's health screening, and Dr. Dan Roach will share his thoughts during the clinical perspective. Before we begin, I would like to remind everyone of a few housekeeping rules. Please keep all questions until the question and answer session. At that time, please raise your hand and you'll be unmuted to ask your question, You may also type your question in the question pane and we will read your questions aloud. This presentation, this webinar is also being recorded, and the recording and presentation will be available on our DCH website. The presentation is also available for downloading in the handout section. If you're unable to download the presentation, please send us an email to hit.info@dch.ga.gov, and we'll be happy to send a copy to you. Again, that's hit.info@dch.ga.gov. And last, there will be a brief survey immediately following the webinar, and we ask that you please take a moment to complete the survey. Now, at this time, I will turn it over to Jeff Jacobs.
Okay, thank you. Well, good morning, everyone. Thanks for your time this morning. We're going to cover a little bit about our clinical quality measure collection project, and want to just sort of give you some of the basics on it, and have a period for Q&A at the end, so as Christy indicated. So thanks for your time. You see on the screen here, you see our the department's mission statement, of course, focused on improving care for our member population. And then we also have the purpose of our project in terms of ultimately improving access and ensuring quality services to the members. As I mentioned, we're going to do a project overview. We'll show you a little bit of the system. We'll talk in detail about a couple of the CQMs that we're collecting, and then we'll have a clinical perspective at the end. Okay, so again, the topic for this discussion is really to share with you about a project that the Health Information Technology team, which is a division of the Medicaid organization, sponsors. And this project is ultimately intended to implement, which we've implemented, and operationalize an effective way to accept clinical quality measures, or CQMs, and to accept that information across multiple channels. At the end of the day, that boils down to a website and the ability to collect that data via an electronic transaction file, if more efficient. We hope then to take the data collected and assess that against trends that we might benchmark, and benchmarks against things that are relevant, right? Geographies, member and disease categories, maybe different provider types, subset of provider types. And so again, we're sort of operating in phases for the project. Our goal at this point in time is not to have 1,000 people participating. Frankly, we're looking for a small group of folks to participate. We want to gain insight on challenges in terms of collecting the clinical quality measures, and then and benefit from lessons learned as we contemplate moving to a broader population. So one of the things that we want to do over the course of the meeting is a couple of points of interaction with you to sort of get your feedback and your experience in terms of a couple of different related topics. And so we want to do that through some polling questions. And so we're looking for you to answer yes or no to the following. Is your practice currently looking for an effective way to capture clinical quality measures? And so if you wouldn't mind responding yes or no to that. Is your practice currently looking for an effective way to capture clinical quality measurements? Okay, looks like we've got yes there, so that's good. And would you drop down on the attendee list? Okay, making sure, okay. So, thank you, and we'll move on to the next question, or the next slide, rather. We do have a couple more questions following this one. Next up. So, ultimately, this project is intended to help improve health outcomes for our Medicaid members. This is a national directive in terms of moving to value-based information, to collect information beyond just claims, right? And so that's really what we're seeing trends is hoping to get a bit of a richer data set by collecting information from electronic health records versus making some of these assessments from claims. We typically do that today through reporting activities like HEDIS reporting and a number of standard measures, but this is, we're hoping to go a step further. So again, it's a platform, it's rules driven, leveraging some standard CMS standard clinical quality measures, and again, hoping to inform providers, inform the Medicaid program on performance and how we might compare against peers and other geographies and other provider subsets, as we mentioned earlier. All right, so our next polling question, I'll jump to this one quickly. Would comparing provider data to state average data benefit your practice? Would having the ability to compare provider data to state average data benefit your practice? Maybe give a perspective on how things compare against state average information. Now, one of the things to share with you, obviously these questions sort of tee up relevant topics, in that is exactly what we're able to do through the application. And so we'll, last chance to respond to that one, and then we'll move on to the next slide. We're going to show you a little bit of what that looks like when we compare the data up against state average data. So we'll move on to the next slide. Okay. So essentially, we have a project team that is ready to provide training to leverage data out of the certified EHR systems. You know, if you participate in the MAPper program, there has been an incentive process for the past several years to support the provider community as folks engage more broadly with electronic documentation and the ability to share information out of those EHR systems. And so we can accept the input. One of the things that we want to emphasize is that we recognize that providers have very busy offices. There's a lot of activities going on. There's a day job, there's a weekend job, there's a night job, there's a lot of activities. So our goal in the project is to collect this data in a really efficient manner that requires very little time, right? Leverages existing capabilities of EHR systems. And again, we can accept a file via what's referred to as QRDA Category 3 file. It's the information we're collecting is aggregate information, so it is not individual level data. We're not getting member information, so it's nice from a PHI standpoint. Or we can accept the manual entry of clinical quality measures, and we can go so far as the last bullet references. We can help with the entry of that data. So you sort of have three different options there. We can pull the data out of the EHR and have it sent to us via a QRDA file. It can be manually entered on a website. We'll show you what that looks like. Or it can be sent to us. You know, a lot of these systems, maybe they're not quite ready to send a QRDA file, but they can generate a report with the CQM measures. And we can key the data for you from that. So the system ultimately displays the information that's been uploaded via dashboards and various reporting mechanisms, and we'll show you a little bit of what that looks like. We also have the participation and support of a clinical advisory board. Had our most recent meeting last week, where we engage clinicians. We have a number of physicians and nurse practitioner and other participants that provide input and guidance to the project, provide encouragement on what CQMs to use, recommendations on use of the data, reports, and a collaboration opportunity with DCH. At this phase in the project, we're really looking to gain that input from our provider participants as well, on their experience in uploading the data and the value of the information that they're able to see. Okay, so next up, polling question. Would you utilize trend analysis or reporting to monitor population health? And in your case, you know, maybe the health specific to your organization's community. Okay, very good. That's helpful. Thank you for the response. We'll move on to the next slide. So let's get specific. Right now, we've got 7 participating provider organizations. We've got about 80 individual providers loaded into the system. We are currently accepting reporting on 7 CQMs, and we are adding, I believe it's 7 more. So we'll have a total of 14. Let's show you those. I think we've got that up next. We actually are going to eliminate one, and it's really because, as you may know, CMS has sort of retired it because the compliance level was so high that the value of the data collected was not quite as meaningful. And so these are the measures. Now, you may notice these are fairly broad measures. They don't necessarily apply to every practice. They are common to many practices, so you may find several. I'll share with you the next slide that shows some of the newer ones. There's some emphasis here for pediatric practices, number of measures related to children, and so we're excited about those CQMs being added to the project. And what that means, of course, is just that we can collect additional measures and more data. Okay, our last polling question, then I think we'll get to some demonstration and show you a little bit of the data, a little bit of what the application looks like. Has your practice spoken to your EHR vendor about QRDA files for clinical quality measures? And that's really, you know, have you had any discussions about sharing CQM data via electronic files? Okay, that's helpful. Thanks again for your participation in that. Let's see what we have up next. Okay, so next up we want to share with you a little bit about what the application looks like so you can get a sense of it. It's pretty straightforward and efficient in its display of the data and collection of the data. So I'm going to turn it over to Teresa Harris, who is project representative with DXC, and let her share a little bit about the application. Teresa.
Thank you, Jeff. Good morning, and thank you for attending. We're excited about the Georgia Clinical Quality Measure System. We have a great application here that will allow you to collect CQM data. So first, what you see on the screen here is our login screen. You will be provided with a user ID and a password, and it will be very easy for you to be able to log in and see access to the application. So our next screen, once you log into the application, you'll be presented with a dashboard. We love the dashboard view. The dashboard will allow you to see CQM data. The representative of this data will be your clinically quality measure information that has been entered into the system compared to the state average information that is also available. Also, you will be able to view the different CQM IDs, which are listed on the right-hand side of the dashboard. Upon clicking one of the CQM IDs, you will be presented with a trend graph for a specific year and quarter. So you can see the how well your CQM measure is trending for that particular year, and then as well as the different quarters. Also, the screen that is appearing now is there's certain clinically quality measures that CMS has identified and defined that has certain statistics measure information. So for this one has a stratum information that's broken out by different age groups. So the chlamydia screening for women is broken out for age group 16 to 20 and 21 through 24. So that stratum information will also be displayed for you once you click on the CMID 153. So how do we get the information into the system? How do we collect your clinically quality measure data? Again, on the application, to your left are several menu options. So if you click the Add View Clinically Quality Measure menu option, you'll be presented with an opportunity to enter the data in a manual or either using a QRDA3 format, which should be provided by your EHR vendor. Once you have selected a manual option, you have the opportunity to see the different CQM data CQMs that will be presented to you. And there you would enter the numerator, denominator, any exclusion information, as well as any exception information. Once you have completed entering your CQM data, we present a summary screen. And on this summary screen, it'll allow you to expand or collapse and view the CQM data that was presented or that you entered. For example, for CMS ID, the numerator had 12, denominator 25, exclusion 2, and exception 1. So I love the summary information. It allows you to kind of just go back and double check what you've entered. Okay, so thank you for participating in this webinar today, and we look forward to working with you and getting you signed up to access to the Georgia CQMS system. Thank you.
So Chris Huckabee is going to share a little bit about some of our specific measures, maybe a little bit more detail on those measures. Chris?
Thank you, Jeff. Good morning, everyone. The first measure that we will take a deep dive into is CMS 125 breast cancer screening. Next slide, please. So for CMS 125 breast cancer screening, the measure description, what we're looking for is the percentage of women 50 to 74 years of age who had a mammogram to screen for breast cancer. For the denominator, we're looking for women 50 to 74 years of age with a visit during the measurement period, and the numerator is women with one or more mammograms during the measurement period or the 15 months prior to the measurement period. Next slide. So who is excluded from this measure? Women who had a bilateral mastectomy or history of bilateral mastectomy, or who have had a right or left unilateral mastectomy. Also excluded are the patients whose hospice care overlaps the measurement period. There are no exceptions to this measure. When does the documentation have to be done for an encounter to count in the numerator? The numerator statement specifies that the patient must have a documented mammogram either during the measurement period or the prior 15 months, and mammogram results are good documentation of a mammogram screening in the patient's record. So when those results come back to your clinic, then this would be a good indicator that the mammogram has been done. Why do we screen for breast cancer? Breast cancer is one of the most common types of cancers, accounting for approximately 15% of all new cancer diagnoses in the United States. The primary risk factor for women developing breast cancer is advancing age. Breast cancer is most frequently diagnosed in women aged 55 to 64, with that median age being 62. So the chances for, statistically, for women being diagnosed with breast cancer in a given year increase with age. For example, at age 40, the risk is 1 in 235. By age 50 becomes 1 in 54. And age 60 is 1 in 25. So what should be documented for this measure? Patient self-report for procedures and diagnostic studies should be recorded in the procedure performed or diagnostic study performed. This measure evaluates primary screening. So we would not include, we would not count biopsies, breast ultrasounds, or MRIs, because those are not considered primary breast cancer screening tools. Next slide. So how will having aggregate data in the Georgia CQMS help me to improve care to my patients? When I log into the Georgia CQMS, the landing page for providers is the dashboard, which you see. I can see fairly quickly that I'm doing a little bit better on CMS 125 than the state average. In other words, I've identified more of my patient panel that had an encounter during this time frame that are between age 50 and 74 that have a documented mammogram screening for breast cancer. The next thing that I can see is that I'm at 53%. And so I should ask myself as a clinician, am I happy with that percentage, or would I like a higher percentage? I should be thinking about things such as, am I educating my patients on the importance of self-breast exams and the importance of staying current on the mammogram screenings? If I click on the number 125 below the bar line or the CMS ID, I will display a trend graph. This trend line graph that shows for CMS 125 that trends over the 4 quarters of a given year. So I can see how I've done in the year 2017 for this slide. Next slide. So our next measure that we're going to talk about is CMS 153, chlamydia screening for women. This measure description is percentage of women 16 to 24 years of age who are identified as sexually active and who had at least one test for chlamydia during the measurement period. For the denominator are women 16 to 24 years of age who are sexually active and who had a visit, a doctor's visit in the measurement period. The numerators for women with at least one chlamydia test during the measurement period. Now, this measure has stratification, which would report a total score, and stratum 1 would include patients 16 to 20, and stratum 2 would include patients aged 21 to 24. Next slide. So our denominator exclusions for this measure are the women who are eligible for the initial patient population due to a pregnancy test and who had an X-ray or an order for a specific medication within 7 days of the pregnancy test. Also excluded are those patients whose hospice care overlaps the measurement period. Again, there's no exceptions for this measure. And according to the CDC, 2017, chlamydia is the most common sexually transmitted bacterial infection in the U.S., resulting in roughly 1.6 million cases each year. Chlamydia infections are often asymptomatic, but if left untreated, can lead to serious and irreversible complications. Women are particularly vulnerable when infected with chlamydia, and if left untreated, can lead to pelvic inflammatory disease, which in turn can lead to chronic pelvic pain or even infertility. Pregnant women can transmit the infection to their infants and could result in neonatal pneumonia. Next slide. So going back to the question of how will having aggregate data in the Georgia CQMS help me to improve the care to my patients, I can see quickly from the dashboard that I'm doing quite a bit better on CMS 153 than the state average, and I am documenting those STI screenings. The second thing that this lets me see rather quickly is that I am at 88%. What does this number tell me? Am I happy with that number? Of the female patients that are between age 16 and 24 that I saw during this measurement period, I have screened 88% of those who are sexually active. I could be thinking about things such as sex education to this population and making sure that this is being done and equipping these young women with how to protect themselves. Again, if I click on the number 153 below the bar line, or on the CMS ID at the right, this will display a trend graph. Next slide. So this is the trend graph for CMS 153 for over the 4 quarters for 2017. And let's go ahead to the next slide. I'd like to point out for those measures that have stratification, this is an additional report that will display, as Teresa had demonstrated earlier. And I can see how I'm doing with each of the age ranges that make up the stratum for this measure. For those patients who are age 16 to 20, I'm at 66% as compared to the state average of 40%. And for those patients who are age 21 to 24, I'm at 30% as compared to the state average of 43%. So this would just give me an additional breakdown of if I needed to do some targeted education to either my high school patients or the women from 20 to 24. And that concludes this portion of the webinar.
Okay, and so Dr. Dan Roach, member of our clinical advisory board, will give Dr. Roach an opportunity to provide some feedback. I did want to thank Chris. That was great information. Thank you, Chris. Okay, Dr. Roach.
Okay, thank you. And you can go to the next slide, please. All right, thank you. So the 3 points I want to kind of go over today are identifying opportunities to improve patient care by using quality measures, and then talk briefly about the CMS quality strategy goals, and then how collecting and analyzing the data can help you. So just briefly about the identifying opportunities. By using this information, it can really help you identify gaps in performance. And I was actually speaking with a colleague, and he was telling me that in his practice, his office manager asked him, how many patients do you have with diabetes? And he said, probably 100, 120. Well, they looked in the EHR and it was about 350. And most of those people just weren't coming to see him. And so there was no way he could have known. And so by using the EHR and actually running some quality information, they were able to find the patients, do some outreach, get them in the clinic, and start getting them on the cycle of, testing their hemoglobin A1C and getting retinal exams and all those different things that you need to do. And so just by having the information, it allowed them to provide better care and get around some of the issues of patient compliance, frankly. And so this is really important as we start moving more away from the fee-for-service type of reimbursement models to a performance-based model where prevention and those sorts of things become very important. So it can really help you along those lines. The second point is the CMS quality strategy goals. And I'll just briefly read the mission statement. It says to optimize health outcomes by leading clinical quality improvement, health system transformation. And we've heard the CMS triple aim of, better care, lower cost, and an improved patient care experience. But if we look more closely at their goals and objectives, there are actually 6 different goals that they list out. And just to go through them briefly, it's making care safer by reducing harm caused in the delivery of care. And a lot of harm that's caused is just frankly due to misinformation or lack of information. And by having information, you're able to make better, more informed decisions. Just again, like the example of knowing how many patients you have with diabetes. The second one is to strengthen person and family engagement as partners in their care. So to really engage the whole family and other people around the patient to help manage their care, as a village, rather than trying to manage it just at a single point of interaction. The third is to promote effective communication and coordination of care. So looking outside of the family now to the different care teams that are involved in taking care of the patient, making sure the information about the person follows them as they move through the care system. Promoting effective prevention and treatment of chronic disease. Again, the example of diabetes, knowing who your patients are, being able to do the right test or the right number of office visits, or being able to manage their care effectively just by having the information. And then working with communities to promote best practices of healthy living, Again, just that's more of the expanding that village out past the family into the community to promote, good lifestyle changes and those sorts of things. And then finally, making care affordable. And I think all of the things before lead to that. So the more you can prevent, the more money you can save. And as we move to value-based reimbursement, the more money you save, the more potential earnings that you can gain by helping to be part of that preventive model. And then the final point is, as we collect and analyze the data, this really is the heart of quality improvement, because it really helps you understand how well things are working, how your systems are working, where there are potential areas of improvement, how do you set measurable goals, how do you track those goals, how do you achieve those goals, and monitor the effectiveness of the things that you're changing to achieve those goals. And we believe that if you're being held accountable for quality management and taking care of folks, then you should have the same information that those people have that are holding you accountable. So that information is there available for you, so that you can also see how you're doing and where you can actually focus to make better informed decisions. And I think that's all I wanted to mention this morning. Thank you.
Thank you, Dr. Roach. Okay, so I think we have come to the close. We do want to share some of our contact information and have some question and answers. So I think we've teed this up. We'd ask if you would submit your questions via chat. Are we going to open up the line there? How do we want to do that?
They can send in a chat box, question box. Do we want to unmute them?
Yeah, so I think we've got a fairly small group this morning. We can unmute, and so we're going to do that. We're going to unmute the lines, and so if you want to submit a question, you can use the question feature or the chat option, or
put as many of them out there as we can, since we only get one.
We've opened the line now, and so
yes.
everyone, if you've got a conversation going, we've opened the lines up. Okay, so any questions?
I have a question.
Yes, ma'am.
Which of the CQMs that we've discussed today are you currently tracking?
Okay, so let's show that to you. If we can go back to our CQM slide, and we also have this information that we can send to you in a brochure. And I think we've got this presentation available for download, right? So if you want to keep this with you. So the slide before this one. And so these are the slides that we're accepting today. And then we are actively modifying the application to collect the next page, which is the new ones. It'll be a couple months before we're ready for those. And so let us show you the next one. So those are our planned items.
Pediatric.
Does that help?
It does, but I'm also curious about the other providers on the line, if they are tracking these as well. And I'm curious if you would raise your hand to let us know if any of these particular CQMs are you tracking in your practice?
This person.
Okay, thank you for that question. Any other questions from the team, from the group? Curious if anybody on the line is actually participating in the EHR incentive program today, the MAPper program. Okay. Well, let's go to the slide that has our email information on it. And, ultimately, as we've shared this information, we are hopeful that you might be interested in participating. This is a 100% volunteer project. We ultimately are looking for providers that, as Teresa showed, can find a few minutes each quarter. We think it really is just a few minutes each quarter. The data being provided is literally a numerator value, a denominator value, an exception and exclusion when applicable value for a short list of CQMs. We also recognize not everybody will have reports for each of those measures. Could be just one of those measures, or could be several of those measures. And so we would love to talk more with you if you'd like to participate, as you saw referenced. While we have several dozen provider numbers, if you will, registered, it's really a small number of organizations, so we're really hoping to grow that and to gain some of the value of more participation and your experience with the application. So we have on this slide a phone number to reach the project representative. We also have an email address. It's for those of you that may not be able to see the email address, gacqms@dxc.com. If you want to shoot us a note, we'll be happy to set up a follow-up discussion with you. Last chance for any questions, any closing comments or remarks? We do have a couple of webinars in the future in June and July. They're very similar to this one, and so we'd like to, as a great follow-up from this discussion, is if we can schedule some time with you one-on-one, and we're very flexible in terms of schedule. Look to accommodate your schedule when we do that. Thank you so much for all the participants today. Teresa, Chris Huckabee, Dr. Roach, and Christy Washington, and our team here at DCH. So thanks for your time, and we look forward to following up with you. Thank you.
Thank you.